Good morning and happy Teach Me Tuesday. I made it out of my bed. It's a miracle. I am so excited to talk about some oral feeding progress today. A little bit about me and my background as a NICU nurse is I worked at a level 3, 4. I mean, it was a 4, but we did not do a lot of surgeries for the majority of my career before my current setting. Prior to working where I work now, I actually had never seen a G button. So it's something I've had to learn later in my career. And I want to point that out because I do think that there's this idea that we all know everything and everybody's taking care of everything and everybody's done everything. And that wasn't true for me. And so I had to learn about that in my new setting. Same with trachs. Trachs still scare me, whereas a lot of people love trachs. It's just never been something I'm overly comfortable with because the majority of my career, that's not what I did. So if you're sitting there thinking, oh my gosh, everybody knows everything, I'm never going to catch up, you will. If you want to go outside your comfort zone, go to another facility maybe one day that's a little different than your current one, or just dig into it with things like this. It's a great plan. But one thing that I did do a lot of is my entire career, I have been part of feeding committees. I'm very interested in what we're feeding babies, how we're feeding them, what we can progress them in. I did a big project as part of my master's program to get more a kind of standardized feeding, so that infant-driven feeding, looking at what is their readiness and what was the quality of the feed. I can tell you when I started in the NICU, so I remember, this was 20 years ago, 20 and a half now, I was sitting in a pod, which is what we call them. We were open bays, and they had a nurse, and she said, I can feed a rock. And I remember that to this day, because what that is that we are feeding the baby is not eating. And I think that that is such an important distinction between what we're doing and how the baby is reacting. It's also one thing if we, as a trained, experienced NICU nurse, can, successfully help the baby eat and the parents cannot, because we're not going home with the baby. So it's so important that we teach the parents what a successful feeding looks like. It also remains one of the most frustrating things in the NICU. You have these babies that are like doing great, they're doing awesome, they're progressing along. Maybe they've gotten out of what felt like the scariest part of their NICU stay, in that they are no longer, having severe apnea and bradycardia. They're no longer on the vent, all of these things. And now we're asking them to eat and they can't do it. And the parents are like, what? I thought we were going to sail out of here. So what we can do is, if they become post-term, we can offer alternative feeding therapies such as G-buttons or NGs at home. So how do we know that a baby is ready for oral feeds? I also remember my career starting, it was like, you do not put a bottle, a breast, anything in a baby's mouth until they are 34 weeks. And now we know that that's probably not entirely true. Yes, they are going to form this pathway, the same thing we have talked about in relation to breathing and that pathway between the brain and the diaphragm. They're going to form a pathway that says, hey, it is time for us to suck, swallow, and breathe around 32 to 34 weeks. But just like apnea of prematurity, oral feeding readiness is not the same for every baby. And that is why once your baby is in a safe place with respiratory, where I currently practice and in my past, that is when they are on less than CPAP, less than high flow of 2 liters, so kind of that low flow, whatever you call it on your unit, and 32 weeks. Then we can start saying like, hey, let's just watch their readiness. Let's see what they're telling us. Are they waking up before cares? Are they putting their hand to their mouth? Are they excessively sucking on a pacifier? When they do skin to skin, are they like trying to find their way down? If they're doing that, then they're telling us like, hey, I'm ready to start doing these things. So watching for those signs and getting started when the baby is telling us is super important. Those first feedings should start with some sort of non-nutritive sucking, whether that is at a pumped breast, I don't like to say dry breast because I don't believe that the breast is ever dry, or with a pacifier, whatever that might be. I worked somewhere we had these things called binky trainers, where it was like a little tube that went in the pacifier and we could control the flow with a syringe. It was super cool. That was really helpful with non-nutritive sucking because we would just give them drops as they were going. We can put them on a plan with breastfeeding so that they learn to latch. Maybe they're starting with licking, maybe they're starting with looking, and then eventually they are latching and doing that sucking. But what we are doing with any of those feedings, especially those first feedings, and as the baby progresses, is we are watching what those barriers are. What is the baby's breathing pattern doing? What is their state regulation? I always think that baby that you're feeding and is doing this like arch, not great, not great. It doesn't look great for them. It looks uncomfortable. Maybe they're trying to pull away. Maybe they're trying to like push the food back into their stomach, whatever it might be. Those babies that have really low muscle tone, you have to remember, if we go back to that first slide, or even if you look here, look at all of these muscles that are involved in this swallow. If they're floppy here, they're gonna be floppy here. It's not like a magical thing where they're like, oh no, the esophagus and the muscles around the esophagus are really well formed, but the rest of the body's not. Those two things do not go together. Low muscle tone in the body is low muscle tone in the airway and the esophagus, all of that. If they cannot maintain stable vital signs during feeding, and that's not like, okay, we drifted down to like 88. I'm talking we're apneic, we're bradycardic, we're having severe DSATs, maybe we get really cold, whatever it might be, that's not good either. And really, these things are what we need to be teaching parents and say, hey, this was a successful feed. Even if the baby took 10 mils, they successfully took 10 mils because they kept their heart rate stable. They had good tone during the feed. They weren't dripping milk out of their mouth because they couldn't handle the bolus that was coming at them. If we could focus on those words as telling us what success is instead of volume, I think our parents would have a better understanding of what we need to do to get that baby home. So the earlier the baby's born, the more likely it is that they're going to have difficulties with feeding and that they're not going to develop this until they are post-term. I think that that's really important to tell parents up front. I talk about that a lot, even at the beginning when parents ask, hey, how do we know when the baby's going to be ready to go home? If your baby is born at 24 weeks, the likelihood that they go home post-term, so past their due date, is much higher than if they're born at 35 weeks. We all know that. We've all seen it. We all know that. I think telling them that early and often is kind of reassuring when we get to this stage and all of a sudden it's like, why aren't they eating? So some things we can do if the baby is having issues is to thicken their feeds. So we have Infamil AR, that's a product. These are just products. I don't have experience with all of them. These are products that are available out there. The thing about thickening feeds, the number one con for me is that the mom can't breastfeed. So if your mom's goal is to breastfeed her baby, either partially or exclusively, our path to thicken feeds should be slow. We should be trying other things before that. Positioning, slower nipples, different nipples, putting something else, in there, having mom recline while feeding so that the milk comes out slower. So we thicken feeds for two reasons. And I think that it's really important to understand the distinction between these two reasons. We thicken the feeds for babies who either have severe swallow dysfunction, okay? That means that the bolus comes into their mouth and they don't know what to do with it. And it's going to take that path right into the trachea and go into the airway. And so what we want to do is thicken it so it cannot do that. And then the other reason we thicken feeds is for those babies with severe reflux, right? With that R word that we don't like to talk about. Those babies with severe reflux, we're trying to prevent it from coming up and down and up and down and up and down between the gastroesophageal sphincter. I always think it's important when we're thickening feeds to ask how we want the feeding delivered if the baby is getting all gavage. So if we're thickening the feeds for swallow, but we're going to gavage the feed, does it need to be thickened? Like, is that a time that we need to do it? Or do we only thicken it when they're doing PO feeds? Or do we need to thicken it all the time because their reflux is so bad that we need to make sure that we're kind of weighting down the food in the belly? There was a huge problem. I cannot remember the date and I don't want to say it wrong, but years ago, okay, let's say about 10 years ago, where there was commercially available thickeners out there and some babies in the United States got neck from them. And because of that, because they are a powders aren't sterile, we kind of stopped using them and said like, hey, this is not a safe practice. And we really need to look at why we're doing it. So they now have other ones available. Most places will not use it until the baby is post-term. We are similar. Where I currently work, it all depends on what week the baby was born at as to what age they need to be post-term. So if they were like an extreme preemie, we're going to wait until they are about 42 weeks before we offer them thickened feeds. Whereas maybe if they were 35 weeks and they have a severe swallow dysfunction, we might do it a little bit earlier. In the United States, there's only one thing that we put in breast milk. So otherwise, we're kind of giving them thickened formula. Again, we know that breast milk is best. So we have to really take into consideration, why are we using these thickened feeds? And is it ultimately, when we weigh the pros and cons of adding it in and getting the baby swallowing and doing all of that, is that going to get them home, which we all know babies thrive at home, or is it going to make them less nutrient dense, then they're not going to grow? Would it be best if we just used an alternative feeding therapy and got them home that way and worked on their swallow in a different way? So one of those alternate feeding therapies would be a G-button. As I mentioned, I did not use these in my previous employment. So I did not know much about them. Where I spent the majority of my career, that first 13 and a half years, this was not something that we used. So I had to learn, right? So for those babies who cannot take, their post-term, we do give them, we had a baby recently that's like born at 39 weeks with duodenal atresia and trisomy 21 and a couple other things. So when they did fixed his duodenal atresia, they went ahead and put a G-button in, thinking we were probably on that path. So that does happen sometimes. Those are the outliers. As I like to say, the NICU is not black and white. So usually we're going to wait till they're post-term. They kind of show us like, hey, I cannot do this. And then we put the G-button in, usually somewhere between 42 and 44 weeks or more corrected. Obviously, if we're trached and all of that, we might get it sooner. So those with severe feeding difficulties, including congenital anomalies, such as what I was speaking of, prolonged feeding intolerance with severe GERD, those chronic medical conditions, heart babies often end up with G-buttons because they just they don't have the power and the stamina to eat. And then those with unsafe feedings, it cannot protect their airway. So those are our primary indications that we in the NICU see for G-buttons. And then when they're in, what we really need to think about is we don't want it to come out, right? A G-button coming out is not just like a walk in the park. So when we feed them, we want to make sure we get them fed. We flush the tube before and after so it doesn't get dirty in there. And then we want to disconnect it because your baby's going to start rolling and moving and doing all those things. So we just don't want that to be connected. We want to ensure there's no excessive pressure on the G-button. If it's dislodged, we want to cover it. We got to keep turning it to prevent skin adhesions. That is super important because once those adhesions are on there, it is really difficult to get them out. We want to watch for signs of infection, including redness, swelling, pus around the G-button. If the infant's in a lot of pain, having a lot of vomiting, so we're cleaning that with the soap and water. And that's how we would do our discharge teaching as well, is to make sure the parents know that. The parents need to be able to set all of this up on their own, get it started using their pump at home, whatever that's going to look like, before that they can take their baby home. Some of our babies maybe are at like 40, 41, 42 weeks. They kind of can take 75%-ish of their feeds and they can't quite get there. They're a safe feeder. They may go home with an NG tube. In my previous practice, we did this a lot. We sent babies home with NGs, after parent education and placing it and all of that. Currently where I work, it is not as common, but it is becoming more common. But this is for those babies that maybe the parents are like, I can do this at home. All we're doing, the baby's not having any apnea, any bradycardia. They are stable in their crib. They're just tiring out. They cannot quite get to that full volume. We'll send them home with an NG and a follow-up with a GI specialist to make sure that we are progressing in our feeding. Their pediatrician's got to be on board with it so that they can be really watching their weight and kind of deciding when we can take that tube out. This is not for the baby that's taking 40% PF, right? Ideally, the thought would be if it came out in the middle of the night, that maybe we could wait until the morning to contact the GI specialist and not have to go to the ER to get it replaced or if something was going on. That they're taking enough PO that they would stay hydrated until they could get it back in. So think of that, is the baby going to be safe until we can get this back in? They would be a candidate for an NG at home. And that's who I would recommend that for, or who I've seen it for. So what we have to really educate our parents about is that the path to full feeds can feel like the longest part of a NICU journey. I mean, there are just so many things that can go wrong here. There are so many things that can kind of delay us. Sometimes a baby will take like 60% PO one day and then the next day take none, and it feels so defeating for the parents. If you saw my Instagram post today, I just was talking about that. I was meeting with a parent, doing some leader rounding and talking to her about, hey, she said, I thought that the baby was going to be ready to go home this week. She was taking 70% PO. I thought it would just get better every day. And now she's not taking any, and she was so sad. And it is so hard because you feel like you're in the home stretch and you just want to get your baby home. And it's just not possible always. We have to really watch these babies for their cues. So reassuring our parents that it's normal for this to develop after 40 weeks, that they can be watching for feeding readiness, that, I'm a NICU nurse. I know what it's like. We have our care times, right? Our babies do at 8, 8:30, and 9. If the babies do at 9 and they're at 8:30 and they're awake and they're eating their hands, maybe we got to get them started first. We got to talk about quality over quantity. The worst thing we can do is to push a baby who's not safely eating, because they are going to get worse instead of better. So watching for those signs of stress. Are they developing stridor? Are they gulping? Are they getting hiccups? Are they completely shut down? Are they disorganized? They look like they're rooting and they cannot get on the bottle or breast. All of these things are things that we can start teaching from that first feed to set the parent up for success of knowing what the baby is going to look like at home. So we're going to start feeds based on baby's readiness. It's so important to know that every baby's going to be different. We don't have one path that every baby is going to follow. We got to watch their feeding cues. That's going to tell us when it's time. And when they're ready and the 2 feeds are decreased, we're going to gradually increase those oral feeds. We carefully manage it to make sure that they're gaining weight, they're maintaining adequate nutrition, they're pooping and peeing appropriately, and we're going to involve our parents in these steps so that when we say, hey, I don't think we're going to get there. We're at 43 weeks. We're taking 30% PO. I think it's time to talk about a G button. It doesn't feel as shocking. So thank you for joining me. Remember, this week we have a double Teach Me Tuesday. We're going to have a Teach Me Thursday to make up for last week. And please reach out with any questions. Have a great Tuesday.